might be aware of the term PMS, premenstrual syndrome, but what about the term PMDD? PMDD, or premenstrual dysphoric disorder, is a severe mood disorder characterized by cognitive, affective, and physical symptoms occurring during the luteal phase in the menstruation cycle. Women with PMDD experience severe mood swings, depressed moods, anxiety, sensibility, irritability, anger, and lack of concentration. They also experience physical symptoms like breast tenderness, swelling, and bloating. Behavioral symptoms like lack of energy, altered appetite and sleep pattern, and loss of interest in activities are also common symptoms for women with PMDD. Women tend to describe themselves as not their true selves when experiencing their symptoms. A major problem for women with PMDD is a lack of comprehensive training and knowledge that many healthcare professionals may lack. As a result, women with PMDD may experience dismissive attitudes from doctors. Stigmatization of PMDD leads to both a lack of validation of symptoms and discourage individuals from pursuing treatment, leading to isolation, worsened mental health, and worsened symptoms. Women may also internalize the stigma, leading them to doubt if their symptoms are real or just part of being a woman. There is a societal tendency to discredit or stereotype women's emotions as hormonal or irrational, which leads to the stigmatization of PMDD as merely an emotional issue tied to women's biology. This gender bias contributes to the underreporting of symptoms, as women may be hesitant to seek help or speak openly about their experiences for fear of being labeled as overly emotional or hysterical. Consequently, there is a lack of acknowledgement of PMDD as a serious mental health condition. PMDD is often dismissed or minimized as just bad PMS, or a normal part of the menstrual cycle, which contributes to its stigma. Many people, including healthcare providers, may fail to recognize the severity and disability caused by PMDD. Many women experience severe mood swings, causing them to feel like two different people, depending on their cycle, resulting in a fractured sense of self. Unfortunately, many women tend to use maladaptive coping strategies, such as substance abuse, self-harm, and negative eating habits. PMDD has also shown to impact relationships and social life due to the irritability, mood swings, and feeling misunderstood by partners. Family and friends are also impacted, as well as work performance by lowering productivity and increasing irritability. Lastly, there are great challenges for women with PMDD to seek medical help, since most of the time they feel dismissed by doctors who tell them that their symptoms are just in their head. This leads to a greater issue of a lack of awareness in the medical field, which leads to misdiagnosis or underdiagnosed. Therefore, this adds another layer of emotional burden to those struggling with PMDD but don't feel heard and seen by medical professionals. PMDD impacts millions of women worldwide, affecting about 3 to 8% of women of reproductive age. Many experience symptoms for the majority of the month, with only 7 to 10 days per month where they feel symptom-free or normal. Therefore, this constant cycle of emotional dysregulation and physical distress causes many women to feel unstable and disrupt in their daily life. Now, let's take a deeper look at the biology of PMDD. PMDD is believed to be caused from an abnormal central nervous system response to normal hormonal fluctuation. Although women with PMDD have normal levels of estrogen and progesterone, they exhibit abnormal mood responses to these hormones. Additionally, brain scans show that women with PMDD have increased amygdala reactivity, which explains the heightened emotional responses, as well as reduced prefrontal cortex activity, which impaired emotional regulation. Lastly, it was found that they have abnormal GABA receptor sensitivity, which may make them more vulnerable to mood shifts when exposed to progesterone fluctuations. Further studies have also suggested a heritable component of PMDD, but more research still needs to be done. Overall, the psychopathology of PMDD is still widely misunderstood and requires more research. In the DSM-5, PMDD is diagnosed when a patient, in most of her menstrual cycles during the past 1 year, has at least 5 symptoms such as affective lability, irritability, depressed mood, anxiety, loss of interest, fatigue, feeling emotionally overwhelmed, and physical symptoms. These symptoms must be present a week before the onset of menstrual flow and improve within a few days after. These symptoms must occur only during the luteal phase in most cycles during the last 1 year and include a cluster of affective, somatic, and cognitive symptoms causing significant distress, interfering with work, school, or usual social activities, and lower quality of life. In order to get diagnosed with PMDD, these symptoms must have occurred during most menstrual cycles in the past year and be absent in the post-menstrual cycle week. Compared to premenstrual syndrome, the symptoms of premenstrual dysphoric disorder need to cause significant impairment and be verified by prospective rating for diagnosis. PMDD is often treated pharmacologically with medications that target different aspects of the disorder, such as mood, hormonal regulation, and neurotransmitter systems. Other medications like benzodiazepines may be used in the short term to manage severe anxiety or insomnia related to PMDD. Diuretics can help manage bloating and water retention, which are common in PMDD. Lithium may be helpful in treating severe mood swings in some patients, and non-pharmacological interventions can also be helpful in managing the symptoms of PMDD. Cognitive behavioral therapy is effective in addressing negative thought patterns and emotional regulation in PMDD. It can help reduce the severity of mood-related symptoms and improve overall coping strategies. It can be beneficial in providing long-term relief as it provides patients with skills for managing stress and emotional dysregulation that might persist and improve overall coping strategies. Dietary intervention and supplements like calcium and vitamin B6 may help reduce symptoms of irritability, fatigue, and mood swings. Some studies have shown benefits from taking calcium, such as 1,000 milligrams per day, during the luteal phase. Magnesium and omega-3 fatty acids have also been suggested as helpful in managing physical symptoms like swelling and mood changes. Dietary modifications, such as reducing caffeine and sugar intake, are recommended to help alleviate anxiety and irritability. Regular exercise is beneficial for both physical and emotional symptoms, helping to reduce depression, anxiety, and fatigue. Yoga and relaxation techniques like mindfulness and meditation can also help alleviate stress and improve overall mood. Improved sleep hygiene can address insomnia, which is common in PMDD. Behavioral changes such as establishing regular sleep patterns and reducing stimulating activities before bed can significantly improve sleep quality in return, relieve mood and energy-related symptoms. So, both pharmacological and non-pharmacological treatments can be effective in managing PMDD, and the choice of treatment often depends on the severity of symptoms, patient preferences, and individual responses. A combination of treatments, including medications like SSRIs and hormonal therapies, along with cognitive behavioral therapy, lifestyle modifications, and supplementation, is often the most effective approach to managing PMDD.